Thank you very much to all of you and to Bryn for that eloquent presentation. The floor is open for questions. And we have only about, what, 12 minutes, Maxine? So we only have 12 minutes. So again, it's not a forum for speeches or anecdotes. We want questions and hopefully to help us drive this research agenda. We'll start over here. Yes.
Well, if you'll forgive something that might be a little in the nature of a comment, I did have some epidemiologic questions about Frank and Amos's work on APGAR scores, seizures, and stillbirth, but I'll reserve them and rather try to frame the question differently. That I accept, and I think we should all accept, that there are risks that have to be addressed. I mean, the lowest intrapartum fetal death rate I know of is shown yesterday, 1 in 2,000 in low-risk deliveries in the UK, didn't differ by hospital or home. About 30 deaths in 60,000 women. 1 in 2,000 in about, say, 12 hours, the average labor. That rate of death, everybody's dead in 3 years. That's a life expectancy of 3 years. It's inherently at the lowest possible level of risk. Labor is one of the most dangerous things that we encounter as humans. And after that, there are low APGAR scores and there are occasional seizures. I don't think the prognosis of those is quite as bad as Frank said, being a student of CP. But having said that, I think we're going to have to recognize that there's going to be a balance. Longer labors with less intervention will lead, and it's okay, I think, to a slightly higher level of low APGAR scores, maybe the occasional extra seizure. I wouldn't like to accept the extra fetal death or neonatal death, but that's probably a price we'll have to pay. Most of those will turn out to be benign. You know, at the same time, I think the obligation of the people who would like to make the out-of-hospital birth larger and more usable is to do exactly what Bryn said in one of her slides, get control of the whole process, standards, accreditation, and frankly, looking at those providers who do undertake to deliver vaginal breech deliveries and say, no, that's not really what we want in our world. We have to define that. I think the out-of-hospital movement has to define its universe and has to really apply standards of quality improvement and standardization that will allow it to become normative in our society, recognizing, and I think this is acceptable, there will be we'll have to tolerate, in order to get the benefits, a slightly higher level of acceptable risk. But it can't go beyond a certain level, and it will go unless the CNM movement gets control of all those practices and tries to professionalize the way medicine has controlled the practice of medicine. Medicine doesn't let everybody deliver a baby in a hospital. Medicine controls itself, polices itself, and if that's applied, then I think we'll have a robust, healthy, out-of-hospital delivery movement in this country.
Okay, I didn't hear a question in there, so we'll move on.
My name is Linda Nanny. I'm on the ACNM board, and I am a director of a collaborative care practice, a large hospital-based practice in Providence, Rhode Island. I also want to tell you, full disclosure, that I 30 years ago chose to have my first baby at home where there was a safe home birth practice, and my second baby in a birth center where I felt was going to provide me the birth experience that I wanted to have. I am now working in a tertiary care hospital, and my goal over the last 30 years has been to provide women with the kind of safe, within the parameters of safety, the kind of birth experience that they want. And we have an in-hospital birth center, which allows me to provide a home-like environment, and I feel very, very privileged to have that availability. So my question, particularly Dr. Chevenak, is how can we make hospital birth more supportive of the physiologic processes that so many women want? We will never get rid of home birth. There will always be a subset of our population that will want to birth at home. And clearly we have to look at that as well. But what I would like to look at is I think the increase in the home birth and out of hospital birth perhaps has been a little bit of a backlash from what is going on in the hospitals today. And so, how can we study or support in hospital birth centers or measures that will increase the possibility of normal physiologic birth and midwife-led care?
For bringing this up. That's what I was going to conclude with. So much of this movement, I believe, has been a failure of the obstetric profession to provide compassionate care. And just Dr. Main, I don't know if he's still here, showed the huge variation in what goes on in hospitals. This goes on in so many aspects of obstetric care. My own area of ultrasound, this goes on. Cesarean section rates, compassionate care. What I was going to close with, I don't know if Dr. Bingham is still here.
Yes,
but,
we're both over
perfect,
here,
yeah,
Frank.
right here, Dr. Bingham, and can I ask her and Dr. Grunbaum? I'm very proud that they pioneered an in-hospital birthing center in New York City at Roosevelt Hospital. Can I ask you, please, Dr. Bingham, can you comment on this? What you were able to accomplish in New York City, which is a tough environment to do this. And I'm saying it is doable. Please, can you say a few words, please? Is
Yeah,
it okay? Please.
I would, I mean, I'm not, it works is all I would say. I think some of it, and I'll put what a couple of my other comments I was going to make, is that we need a paradigm shift in our country. And the way in which the birthing center in Roosevelt worked is the approach was that every woman should have access to evidence-based care, and birthing center care is evidence-based care. And I actually did something controversial for some people, is that I made the same policies apply to the more interventionist floors, so that the women wouldn't have two standards of care regardless of where they chose to have a baby. And I think that's an important point to be made. However, there is within our current system, unfortunately, and I don't think there's a way. I just think we have to acknowledge it. It's like racism. We don't always know. We don't always are aware of our own biases and how they impact the decisions that we make as care providers. And what I mean by that is we don't always see the flaws inherent in our own behaviors. And that's what I mean by a paradigm shift, a shift of we've got care providers who, a system that's been set up with certain kinds of politics overlaid on it in a way that not everyone has the same kind of voice. And what made it work at Roosevelt is the midwives had powerful voices in that hospital and were recognized as equal partners in that system. And that made a big difference. It was a collaborative approach to how care was delivered.
Sorry, can you wrap it up quickly?
That's
I'm
it.
conscious there are other people want to.
Yeah. So just those two things, the paradigm shift and the built political environment.
Thank you. Could we have one more question, Maxine, or two? Two more questions.
I just wanted to comment on Dr. Chevernek's presentation and about the birth certificate data. Neonatal seizures, the full variable is called neonatal seizures and other neurological disorders, so it's more than just seizures. And it's one of the items that's considered to be very poorly reported on birth certificates, and I think it was also on Dr. Main's list of items that are very poorly reported. In regard to the 5-minute APGAR score, I don't have direct information on the quality. Maybe Dr. Main does, but you showed that clearly it was poorly reported for the APGAR scores of 10. So it makes me wonder how well reported it is for the lower APGAR scores as well, and that's an issue. And I did have some data facts down this morning on infant mortality by place of birth and provider. And I haven't published this because it's like comparing apples and oranges. It's not risk adjusted. You can't follow up the home births that end up delivering in the hospital and so forth. So that's why I haven't put it out there. But just to say that it's not as dire as maybe your presentation showed. You know, this was 2009 national data, linked birth and infant death certificates. The total infant mortality rate 6.4. Birthing centers is 2.0. And home births delivered by both CNMs and other midwives, it's 3. And I'd be happy to share that with the panel. And the other thing I wanted to say is, even if it is a little more risky for home births, what do you do about that? I mean, it seems like your solution is to, okay, if it's more risky, let's shut it down. My solution is the other way. Let's make it safer.
No, no,
And the way to make it, can you
Ellen,
let me finish? The way to make it safer is to license the midwives, you know, have uniform training, have support for transfers and all this, and make it part of the healthcare system so you can work the same quality measures that you're working at hospitals. And that's the future.
Ellen, I have to be able to respond to that. Am I allowed to respond?
30 seconds. And another 30 for Bryn.
A few points. I hope you did this just for term infants 2,500 grams or above when you did this statistical analysis. That's the first comment.
I didn't do any statistical analysis. I just had a
It's
work
quick and
table
dirty.
facts
Okay,
down.
fine. Okay.
Facts down, but still,
Yeah.
even if you can include the
You
low
have-
birth weight and everything else,
No,
2
no.
per thousand is pretty low.
No, no. If you include in the hospital births all the prematures, it's going to skew everything. You realize? Please, you're the.
Of course, that's why I never present this data. What I'm saying is, what I can say is the absolute level of infant mortality is very low for home and birthing center births. I'm not talking about risk adjustment. I'm not talking about risk ratios. I'm talking about the absolute level. That's all you can say with
carry
vital
this
statistics
discussion
data.
elsewhere. Can I
I
address
don't
her other
think you
point?
can say anything else.
Stop, halt. I will take the prerogative of the chair. I did say that Bryn could say something since we're talking about home birth, and then I'm very sorry, but we have to shut it down, or Maxine will get me, so.
I just wanted to make the point that in the question around making hospital birth a more conducive environment for physiologic birth, one of the things that I mentioned in talking about the woman in the photo was the experience of her being unencumbered. And I think as a home birth clinician, I can also say that I am unencumbered in a way that physicians and providers in a hospital can't experience. And we haven't really talked about the liability drivers that affect that for physicians. And I think it's one of those polarizing things where we think this is just a philosophical or an ethical or perspective issue, but there are encumbrances that we could look at to try to remove some of those things that make it very difficult to provide this kind of care in the hospital.
I can indulge 20 seconds here. Dr. Bingham and I are working through a quality measure for hospital level care that is about as close to physiological normal birth as you can get, which is women at term singletons who did not have an induction, had a normal spontaneous birth, no episiotomy, and as close as, and that will be, I think, a very interesting consumer tool to look at in the future. Not here now, but it's working through the system. Thanks.
Thank you very much, and thank you, everyone, for your presentations and for your questions.